Thank you. I wish I had as poignant and as insightful remarks as Danielle thinks I have as we go forward. But as we go on this journey, we're on this journey and have been on this journey for a long time. I look around the room, and I may be amongst the oldest in this room. And as we recall, throughout the course of healthcare, we've tried to figure out how do we make sure that we know everything about patients so that we can help treat them. And there are many grumblings of the forms and things that we have to do in healthcare. Psychosocial exams, how many physicians don't like that those things have to happen, but how many great things have happened from the fact that we found out that children were eating lead in their homes. And then we found out we wanted to know more about their homes as we went through. Medication reconciliation, I hear about that all the time, but if we don't know what medications people are on. So how do we engage patients in a way that helps this come together in a natural way as opposed to what feels like an unnatural way sometimes with the way that we're trying to gain information? So I am certainly not the expert, but I am certainly passionate about what it is that we're trying to do to engage patients, to have them be a member of the healthcare team, not just the person who happens to be at center stage as we're trying to take care of them. And I've been on this journey in my healthcare career since I started, knowing that our patients have choices, but our patients also trust us to make the right choices with them. And how do we do that if we're not all engaged together? So I want to talk just a little bit about what I mean by a few of these terms as we'll go through today. And so as I talk about patient engagement, I think of that as the providers and the patients working together to improve health. And it's not one side over the other. It's both of those folks coming together. Again, I think time and time you can read study after study that says the more the patients are engaged, the more likely their health outcomes are more in line with what we would expect them to be. It doesn't always mean that they become illness-free, but it does mean that our outcomes become better. You know, as I was on my healthcare journeys of working in healthcare, I've had the opportunity to work with a lot of technology startup companies. And in one case, about a decade ago, there was a new company that was coming into play in what would have been the external telehealth market. They were going to sell us telehealth. And as part of coming forward to look for venture capital funds, they had asked the people on the board to utilize the care that they provided to see whether or not we liked this care or not. And I decided that I was going to ask my at the time my son was 20, I asked him, here's a script. You can call up this place and tell them you have these things and see how they take care of it. And please just tell me how your experience was with it. I don't care if you liked what they, just tell me how you felt about it. And so like any college junior at the time, he waited about 3 or 4 weeks before he did anything about it. And then one day he called me really kind of out of the blue at a time he wouldn't normally call me and said, "Mom, thanks for giving me that card. I'm never going to the doctor again." And I said, "Oh, tell me about your experience." And he said, "Well, I looked at the thing and I can't lie. So I couldn't tell them I had those diseases. So I just decided to talk. And the thing that was on my mind at the time was whether or not I was eating too many green leafy vegetables versus beta-carotene vegetables versus these kind of vegetables. And I wanted to know what that made a difference in my health." And the physician who I talked to, got a registered dietitian on the phone with me, and we talked for 20 minutes about the best balance of foods for me as I was working out and going to school. I don't ever want to go to the doctor again. Well, I think the cards that we were provided by this company were all about whether you had pink eye or whether you had an ear infection or something like that. But the health care that my son was looking for was health care, not sickness care. And I think that one of the things as we engage our patients, we may think, hey, we need to have all of these things provided for when you're sick. But our patients don't want to always be sick, and how do we look at that as well? So I think patient engagement allows us to think about how are we looking at healthcare in a multitude of ways. When I talk about digital health, I really am just talking about anytime we're using technology in the game. How are we getting applications and technology into this space? Nothing special of this technology is digital and this one isn't. Although we have digital health people and they may describe it differently. And then really patient experience. How do you feel about what you got? This isn't the my health score or something changed in that, but did I feel listened to? Did I feel important? Did I feel that they heard what I had to say? You know, studies as we go through patient experience have way more to do with billing questions and appointment questions than they have to do with healthcare questions. And these are still, in every survey, these are still the number one things that our patients ask for. They ask for online scheduling, but online scheduling with the airline experience, not the opportunity to email you and tell you, I might like to come on Tuesday, do you have anything open, and have a back and forth dialogue. They also want a bill, and especially those of you who are in academic, and I assume most of you have an academic background or know of that. In an academic setting, you'll get 27 bills, you know, from everybody and their brother as it goes through. And just when you think you've paid for everything for a particular experience, one more bill comes 13 months or 12 months and 30 days or 29 days later because you only have 13 months to bill for things. So it's very frustrating to our patients. And those things are not high tech. As we go through the process, those things are things that we can talk about and are very much more culturally driven than they are technology driven. So let me talk a little bit about what we're doing here. We have a project in place called Destination One. And Destination One is a project that we started, well, it's been ongoing in the thought process probably for several years here at UW Medicine. But as I came, and I've been here for about not quite 18 months, but as I came on board and asked the questions, why are we trying to go, what was brought to me is we need to go all Epic, as we're a hybrid shop of multitude of systems. And I said, well, why do we need to go all Epic? What are we trying to achieve? And the questions came about saving money, about ease of access. But I kept asking the question, well, what will our patients ultimately will pay for this, what will our patients see as we go through that? So we really want to make sure that we're improving the health of the public we serve. The opportunity to gain data in a way that will help us research that is, in fact, better in the way that as we gather better information as we go through that. The opportunity for our patients to have a more complete record is better because we have one place for people to go and they don't have to look in a multitude of places as we go through that. And the opportunity for our patients to seek a one place to come and meet with us is a better opportunity that they could stay engaged. So as we looked at this turned around not to be all about how do I save some money and be on one system, but how do I look at one patient, one view, one story as we go through this, and what does that mean in the healthcare journey? We're moving all to Epic, and it is not a tagline. This is not an IT project. As we move through this project, it will not be successful. I see many of my IT colleagues here in the room. I can put an EHR in very quickly. I can put one in very quickly that will work. I can put one in very quickly and very cheaply that will work, but nobody will want to use it. It will not engage my patients. It will not engage my physicians. It will get the job done, but it won't be the right system as we go through that. So how do we do that? So as we do that, that journey is going to be led by the people who do the work. We have 20 clinical committees that are working on everything from radiology to order sets and kind of everything in between. Every one of those committees is led by a physician and a clinical or administrative dyad partner. IT's at the table. We are professionals and we understand how the ease of some things and can help be a partner in that. But we can't say, hey, wouldn't you rather treat your patient this way than this way? Because we're not treating our patients in that process as well. We want to make sure that this is a partnership. This is the kind of the moniker that we've used then of what are we trying to accomplish in our Destination One journey. It's circled, and it always is at the center. This has been a picture. I didn't make this picture for this event or anything. This has been the picture that we took to our Board of Regents as we talked about what did we want to accomplish. And what we want to accomplish is engaged patients with a great experience. We want to make sure that those patients are circled by high quality care and safe patient care as we go through that. And how do we help the people who do that? We want to make sure that our physicians and our clinicians have a better engaged and better experience in the process. We want to make sure our nurses have opportunities to have workflows that work in the way that they work, not in the way that a computer system tells them to work. And we want to make sure that we have the opportunities for, as we go to single systems, have efficiencies in that process as well. And there are significant efficiencies that we in our organizations are finding in that as well. As we looked at patient engagement experience very specifically, there were some very key issues that we had in our environment. One of them was how do our patients connect with us? So our goal is to go to a single online portal as we go through that. Our goal is to make it easier through that portal to have better online services that are more intuitive for our patients as well. And then create more opportunities for communication between patients and their team members. All of those other areas also have high-level goals as we go through it as well. But these are the ones that kind of talk to that as well. In our current state, we have more than 8 portals that our patients can come into. I'm generous in saying more than 8 because we don't have 9, we have more than 8 as we go through that as the process. And as you can see some of those screenshots, they all kind of, you would think that that is the way to get into UW-Medicine, but if you were looking for a bill from your physician versus the hospital versus an ED in one of our locations, you would go in a different way to find that as well. But you might not understand that when you got in there, and you might not understand that the bill from your physician for the same stay might be in a different portal than the bill from your hospital in that same stay. If I have difficulty paying for something online, I just say, well, they clearly don't want my money. I'll wait till they send me a paper bill, and then I will pay it, and they will get their money significantly later as it goes through the process. And I'm also the person who stands in the wrong line at the grocery store that has one person, but then 27 people go in the next line over. So I get frustrated pretty quickly as I go through that. So our goal is moving to a single patient experience. Now that patient experience for us isn't defined by our vendor, but defined by our patients, our clinicians, our administrators of what do we want in that two-way conversation as we go through. So while we are an Epic shop and we will look at MyChart as part of that process, we will look at Apple Health Records because our patients don't want to always have the vendor or the hospital owning their chart. They want to have a more intuitive place where they can put things from other places because they might not want you to know that they went to a podiatrist in another system or something like that, but they want to have those records together. So how do we make sure we're working with them so that we can still have the right level of communication, and many of those offline records like Apple Health Records let you connect to your MyChart, but also let the patients be in charge as we go through the process. This is kind of just our quick journey. We are building our system right now, and we'll go from build to test and train and go live. Our go live date is out there as an April date. We're still working through one go live or two, whether or not what month that will be, but the only thing we know for sure is it will be in 2020 as we go through the process. So I kind of leave you with something that I try to instill as I'm talking through is we can fix today's problems. We know what today's problems are, and we can all spend time either by ourselves or with consultants or with our teams and fix today's problems. And while we're fixing those problems, more problems will occur, and we will be in the ever-ending cycle of continuing to fix problems. I think the opportunity in patient engagement is that opportunity for us to dream about where do we want to be. Where do we want to be with our patients? Where do our patients want to be? Let's talk to our patients about what's their desired health status, not how do they want to interact with us, but where do they want to be? And how do we look to catapult to that as opposed to the never-ending fixing yesterday's problems as we're going through the process, and dreaming about the opportunities that exist, and dreaming that in today's environment of new technologies, of new, we're all tethered to our phones as we go through that, new opportunities to do things in a more intuitive way, and even new opportunities to look at the age of our patients and what they're looking at. What my children are looking for in healthcare and what I'm looking for in healthcare are completely different. But the experience that we have can be the same, or that same opportunity. We're all on many of the same social platforms for us to communicate. And but our experience in those is different to each one of us, but it's still the same platform that does it. So I think there are great opportunities for us to continue to move that forward, to see where it is we want to go, dream about it, and take that dream to the next level, because certainly that will be noticed by our patients as they have choices in how they seek their care as to being different from the rest of the marketplace. So I'm happy to open it up and ask you if you have any questions either about our program or anything else that I may be able to answer for you. Oh. I've answered every question that people could think of.
We're good? Okay. Yeah, and we intentionally structured the agenda today so that there would be time for discussion. So if there are any questions, she's a captive audience, and you have that ability to ask. I'll start with the first one.
Absolutely,
today is about thinking about the future. What do you see as some of our greatest opportunities, but also some of the greatest barriers? In the next, we'll give it a time frame too, like in the next short-term year or so.
Yeah, I think some of the greatest opportunities really are that opportunity to connect in a virtual way that some people, especially of the legislative age, we kind of talk about the 70-year-old and older legislators who think that people do not want to go on open health forums and talk about what is wrong with them, and they do. People do not have that security concern about some of their own health questions as they go through that process. And so I think the opportunity to look at how do we structure privacy and security rules in a way that is indicative of how people want to engage in their healthcare. Clearly, we want to keep data safe. I don't mean to say everything becomes open, but there are restrictions in the way that we can share data today that really could have some opportunities in that as well. But just the straight online phone opportunities, how do I change my scheduling? If I can schedule easier and the technology's there to do it, how do I get a single bill? How do I do some of those things that are just top of mind for our patients today? I think those are all doable tasks because we've seen people across the country doing them. And people who have gone to programs like insurance programs, value-based contracting that have downside risks have found the only way that they'll benefit in those is if they keep people out of the hospital. So, again, when I went to school, it was a bed built is a bed filled. And now we're looking at how do we make sure that, we're seeking more of our care in our homes, or on the phone, or in our workplace than we are coming into the bricks and mortar as we go through that. But therein lies the barrier. Those of you who are physicians in the room, we weren't trained as physicians. We didn't train physicians to do online visits as we go through it. It's difficult. You learn to touch, to look, and things like that, and there are different tells as you go through that. So how do we also look at our curriculums to make sure that we're training our physicians? And many medical schools have changed some of their training programs to insert some of the how do you do things online, both from a how are you seen and kind of even that logistics of how do you do virtual care, but also from the standpoint of what are the tells that you're looking at that you can look at much almost as clearly as you can next to them. You just can't touch people. But now we have tools that let you touch people as well. We have devices that we will see very shortly that can know a lot about us from just wearing them every day as we go through that. That data is now, from a machine learning and an AI perspective, going to be able to start funneling into some places that make it useful. In the past, when people got on Fitbits, not every physician wanted to know how many steps you walked every day. But I do know orthopedic surgeons who did want to know if you walked the day after your hip replacement. They did want to know that you got up 4 times during the day after your knee replacement and did your exercises. So there are times where that information, even in its rawest form, was important as we go through. The barriers, though, continue. You know, culturally, we've been set up to be a bricks and mortar, come to us type of healthcare environments, and we need to look at coming to our patients as well.
Yeah, thanks, Danielle. I was intrigued by your comments about Apple Health and the ability for patients to own and manage their own data. Mm-hmm. And then you just brought up this idea of steps, steps versus did you walk yesterday, mm-hmm. which kind of brings up sometimes there's a mismatch between the way patients view their data and view the granularity of the data that they'd like to manage and the way that data is clinically useful. So I'm kind of, and I guess the third point that I would make is just that the systems that we think about from an institutional perspective are systems that are focused on meeting the institutional needs, the large systems like Epic, Cerner, so forth. And so I'm curious what that interface looks like between patient-owned data and institutionally generated and managed data, mm-hmm. between the different granularities, the different views of importance of data, and how do we sort of tackle that from the institutional side?
Yeah.
One, if you look in the Apple Health app, there's this simple set of on-off switches. What data do I want to import? What data do I want to share? Is it that level, or is what are people saying about that?
Yeah. Where's Sally? Oh, there's Sally. I think from the beginning of time, since we wrote something on a piece of paper, there's been kind of a challenge of who owns the medical record. It's oftentimes talked about, well, the data is the patient's, but the record is the institution's as we go through. And I think it becomes very semantical as we go through the process. What we keep a record for, yes, we need to bill, and I don't want to take away anything from the how do we continue to make money so that we can invest in the care of our patients as we go through that. I don't want to take away that there aren't a lot of logistics as we go through. But as we are patients, as our patients look at their information, how do they help discern something from that? And it is always their choice of how do they keep their data. So I think that there are great opportunities for our patients to own their information, and technically if they only want to import half of their data, to look at some of that. But then, like anything else that we would share with a professional, if you have complicated taxes, you can bring in all of your tax information, but you might want to bring in an accountant to help you discern what are your best opportunities to move forward. There are patients who want to only look at WebMD and decide what their own care is. They can't prescribe for themselves. They can't do those things, so they do at some point usually have to involve somebody else in their care. But I think the more that they own what it is their health, is their sickness, is their data helping them through, the more we have that opportunity. I also think we're going to see a wide variety of apps that are going to help in this process as well. The virtualization of data and the ability of that data to help care for patients. I have a friend who, she sold the app, but had an app that was for mental health patients that was actually just to check in on them every day. It was a virtual bot that just, talked to them every day. And their scores improved so greatly just with the app, and it clearly is we're reaching out for relationships as we go through that. The same thing happens on a lot of surgeons have a particular pre-op and post-op, and people prefer it on an app. Most people prefer it on something that they can take with them and go, as opposed to a piece of paper that they lose as we go. So I think that integration, kind of the lines start to blur between the who owns it, where do I store it. It becomes, if we gather into a relationship, I think we in fact share that data that we want to. Personal opinion though, yeah.
When you're talking, you're bringing up a lot of devices.
Yep.
How do we stay on top of that, have it accessible, to all our, the population? I deal a lot with the safety net, but I'm talking about access to devices.
Yep.
Even in our inpatient unit, if they're going to be interacting, how do we make sure they have the right one and we keep up with all the device change financially? What are your thoughts on?
So the most widely used device today is a phone. People who don't have a home have a phone. Prior to smartphones being so widely used, it surprised many people that one of the highest utilizers of online resources was the Medicaid population, and they accessed them in public libraries. And so I think there's always been kind of that connection. I don't think that we need to dictate, are you using an Android phone or a iPhone? Those are the two major operating systems that even the pay-as-you-go plans use as well. And so I think we worry less about the devices. We worry more about how do we make sure that it's helping our patients in the right way. The physicians in the room can probably tell you of the time that patients go into WebMD and say, hey, but it told me to do this, and it's completely backwards from what you're supposed to be doing. We need to make sure that their apps are helping them in that direction, but especially in some of the ways to seek balance and wellness, sometimes that's a personal choice of the patients as well, and we should less dictate what that is as opposed to saying how would we interact or how would they interact with it, and let them know how we'll interact on the healthcare scene and how they can garner that data. Things like the newer Apple Health Record allows you to import from places as well, so folks can do it as well. I think the more we dictate and say you have to use this app on this phone to do it this way, the less likely we'll engage with patients. Yeah.
So I'm curious, as you develop new e-services and launch them, if you're seeing new professions emerge or how the work changes. And I like the view of having the people who are doing the work lead the projects, but I also wonder if that creates blind spots about ways to rearrange the work because of biases there.
Yeah, I think it is, I have told my teams this many times, I think that it's great to continue to bring in new blood. I think there's great opportunities with student internships. I have a story, it's a very IT story, but a problem that existed for a long time in an IT shop. And we had an intern that came in for the summer who was the laziest intern I've ever seen in my entire life. But when we, at the time, this will date how old it was, when we had to figure out how were we going to have 10,000 people touch a system at the same time to see if the load balance would work, and we couldn't figure out how to do it other than pay 10,000 people to get on the system. He built a second city to put 10,000 people and touch the system. So I think there's times that you're just like, oh yeah, I should have done that. That you need to bring in that light, especially because what's important to people changes and how they utilize things changes. So I think there's opportunities to look outside the walls. I can't stress enough how important it is, though, to have active relationships with patients in terms of what do you want, what's important to you in other things that you do online, so that would you mimic that in your healthcare too. So. Sorry, Jane, you can't ask a question. No, I'm kidding.
I think we've made great strides in pulling in external information into our records in a number of ways. Certainly our interoperability and things like Care Everywhere have revolutionized our ability to provide care across the systems. And we've done quite a bit of work on trying to get patient-provided data into the charts. I think we still face some technological problems with our vendors being able to incorporate that information in a way that's easily accessible and helpful to providers. But we also find that providers are on some level overwhelmed with the amount of data coming in from a variety of sources. And one of the things I'm curious about as we go through the day today is how we provide ways for clinicians to make sense of and appropriately use the data that we're bringing in from patients.
Jane, I think it's a great comment, and actually I was speaking to our speakers ahead of time about speaking later a little bit about the burdens that we place on our physicians for billing, for reporting, for new contracts, that all of a sudden they have no time to actually spend with the patients anymore. They're filling out forms as we go through, and how do we help with that process? But I do think that it's important to look at the precipice of where we are and the practical use of artificial intelligence. We have so much data that now it's getting to this space where that machine learning can start to do something with that. We have to be careful because it does what we tell it to do, as opposed to completely knowing how to do things on its own. But we are to that spot where we can start doing that. And in those areas that we've actually had data for a long time, like in sepsis care, we can really start doing some things to see where does that right sweet spot go for that. And hopefully start presenting our physicians with information findings from the chart, as opposed to them having to go through the entire chart to pick those all out. Again, certainly our physicians still have to do something with that data. We wouldn't want to say that we're asking artificial intelligence to care for the patients, but rather to cull the data at this time to go through it as well. I think I think we're right at that sweet spot to start looking at how do we utilize those tools. Yeah.
Something that I find on some of the apps that I use, you can access like the blood records and things, but you can't get to the notes on mobile apps. And so something that I personally like to review as a patient is to go back and make sure that I've covered everything, or that everything's been communicated. It's just something that would be nice to have as a priority, where you can get it online, but you can't get it off your phone.
Yeah, a lot of that has to do with just how people set things up and look for what people want in those apps. And so lots of times we turn off the notes as opposed to that they're not available. So I think sometimes we have to look at how do people want to consume data? How do we make sure it's there consumable? I mean, nothing frustrates me more, although I'm in a technology field, than looking at a website on a phone that's not enabled for a mobile device because you can't read anything. But then flip side, go to the mobile app that they have and have like 3 pieces of data, and you have to go to the full site to get anything else. So I agree. I think it's a thing. I am a person who in the bottom is sending notes to them to say, I need to see this. What about this? You know, it would be better if you did this, and things on the apps too. So I think you can do that on the apps that you like too. And we as providers need to hear that as well. We need to, our patients want to see those notes, and there's projects going on with our notes. There's projects going on across the country that look to open those things up more in a more intuitive and a more readable fashion for our patients as well. So, yeah, thank you. Yeah.
Thank you very much.